with Project Echo, University of New Mexico. These sessions are held on a weekly basis on a Wednesday, and this afternoon we've got the honor of Professor Hale to guide us through some interesting liver histology in the presence of systemic illnesses. Throughout the talk, the chat will be open for questions, and we will try and address those as we go along. So, Prof, thank you very much for this afternoon, and let's see what you have. We've got 3 cases. The first case is a Miss NN. She's a 45-year-old female, previously diagnosed with nephrotic syndrome by our nephrologist, had protein creatinine ratios of 12 grams of urine, 12 grams of protein per 24 hours. A renal biopsy was performed, which was in keeping with AL amyloid. On further workup, her bone marrow did reveal clonal plasma cells in keeping with the plasma cell dyscrasia. She was thereafter treated with melphalan, prednisone, and bortezomib, and a year and a half later now presents with a hepatomegaly of 18 centimeters, an infiltrative LFT with an ALT, AST in the normal region, ALK phos of 256 and a gamma GT of 699 with normal bilirubins and normal synthetic function. Workup for hepatic viruses, autoimmune liver disease were all negative, and we proceeded to do a liver biopsy. Prof. Hale.
So thanks, Dylan, for that introduction. And as always, it's a pleasure to be with you, and thanks for inviting me to present some interesting cases. And as you suggested, the title of today's talk is the hepatic manifestations of systemic disease. And I think we've got some 3 interesting cases, and a couple of them, or one certainly, has got a twist in the tail. And we'll start off with the first patient. And this particular patient, if I can share the biopsy, let's see if I can share my screen. Yes, I can. Right, you should be able to see that screen now.
Yes, it's come up, Prof.
Right. So thanks, Cheryl. So we've got here then is a liver, which at first glance you probably say looks all right. We go through it, but those of you, I'm sure you're already seeing, we've got areas that appear somewhat paler. These sort of areas here, you can see that. And I think what this biopsy starts to demonstrate is the tremendous reserve capabilities of the liver. And I'll elucidate that in more detail later on. If we look at the reticulin stain, you can see that the reticulin framework is largely retained. I think you can see the trabecular framework here. Hasn't picked up in all the areas, but the reticulin architecture is fine. So you've got portal tracts, for example, at the bottom there. That's the portal tract. And then we have a central vein. If I can just see if I can pick that up. Let me just try turning the screen. No, I can't quite get it into the field. So I'll have to go down onto lower power. But what we've got is a portal tract there, got a central vein there, and the architecture is fine. And if we look at the mass on trichrome, or in fact, let me put on a serious red. That's usually, in fact, no, I'm not going to put on this. Let me try that, just see. So the Sirius red shows the same sort of thing. You can see so there's the portal tract there, a little bit of fibrosis and collagen in the, or normal collagen, I should say, in the portal tract. And there's a central vein, and that's a perfectly normal central vein. And typically the central vein has this very thin rim of collagen. So when we look at liver biopsies, in fact, and this is actually a very good biopsy really to demonstrate the normal quantities of fibrous tissue or collagen that you get in a liver biopsy. Because often even in the perivennulates, such as this, in our so-called normal biopsies, we will see a little bit more collagen than you're seeing. But this is actually this is a perfectly normal central vein. So that's useful. I know there are some of the registrars on the meeting as well. And just for your information, really, just to show you what the normal collagen is around a central vein. So any more than that is worthy of reporting. And then that there is a portal tract, and once again shows a normal quantity of collagen in the portal vein, at least in the portal tract. Right, so we looked at the architecture of the biopsy. Let's go and have a look at the liver. So you heard that the liver was enlarged, 15 centimeters in size. And then when we have a look at this, you can see that we'll go to the portal tract, or one of the portal tracts, and you can see that, remember, with interpretation of liver biopsies, like everything, you need to do it in sequence. If you don't do it in sequence, it doesn't really matter what sequence you use, but you must do it in sequence, because if you don't do it in sequence, you forget to look at things. And it's important that you do so. And in my own particular sequence, I always start off with the portal tracts and the architecture, because that tells us a lot as to whether there is acute liver disease or chronic liver disease. So here we've got a portal tract, and it's nicely demonstrated. You can see that we've got the hepatic arteriole there. We've got the portal vein there, which is fine, and you've got a bile duct there, which is fine. And notice that none of those structures are enlarged. There is no evidence of any bile ductular proliferation, and there is no evidence of any lymphocytic or other inflammatory infiltration, be they neutrophils or epithelioid histocytes. So that's a perfectly normal portal tract. Now, those of you who are astute, and I'm sure all of you have picked this up, you can see that what we've got is that we've got the hepatic plates here, the trabeculae, and in between the trabeculae, we've got this amorphous, pale staining or lightly eosinophilic material, and that is amyloid. And what's happening is that the amyloid is being deposited, and it is compressing the hepatocyte trabeculae. And if you want to see what the normal hepatocyte trabeculae look like, that's an area there where there's a little bit of thinning, a little bit of atrophy, but these are probably trabeculae that are of normal thickness and normal width. Whereas if you go down here, you can see how compressed they are. So this is a very good example of amyloidosis. And I mentioned the reserve capability, and certainly if you look, for example, here under low power, you can see the extensive compression of the hepatocyte trabeculae that the amyloid is producing. And you'd be surprised at how much amyloid is deposited in the liver, and the hepatic function is normal. And that is, there's a little bit of obstruction here, but with an elevated gamma. But often the liver function, in fact, is completely normal. So it's all very well to say, yes, that's amyloid. That's a textbook case. And for registrars, I don't know if there are any Part 1 registrars on the meeting, but this is actually a very good example of a Part 1 site. You should be able to recognize amyloid. Now, when we come back to the portal tract, so I've shown you deposition of amyloid within the parenchyma, but you also need to look at the blood vessels. And if you look at this particular blood vessel here, we return to it, you can see that there is no deposition of amyloid in the hepatic arterioles. Now, I mention that because in some patients, in fact, you may only see amyloid deposition in the hepatic arterioles and not actually occurring in the hepatic parenchyma. So if a patient, for you know, has a plasma cell dyscrasia, myeloma, or something like that, you must make a specific point of looking at the hepatic arterioles, because this deposition of amyloid in the hepatic arterioles can be extremely subtle, and you can miss it very, very easily. So you need to just have a look. When you look at the liver biopsies, just take a specific look at looking at the hepatic arterioles. Is there amyloid, and is there or is there not? Because that may only be the site of amyloid in the liver. But in this particular instance, we've got lots of amyloid in the sinusoids. So, good example. So now let's move on to the special stains. So I put on the Sirius red, and the Sirius red is a modification. It uses the same reagents as does the Congo red. So you can, with a bit of luck, also see amyloid deposition on Sirius red staining. And there you've got it. And you can see this is the sinusoids here, and you can see this amyloid deposition. Okay, you can see this faint coloration. And then if we look at the Congo red, and this is a proper amyloid stain. And always have a look at the control stain to make sure it's worked. So this is a bit of kidney. This is so-called myeloma kidney. And here you've got extensive deposition of amyloid in the interstitium, which you can see there. Now, we talk about this as being salmon pink in color. Histopathologists always equate, I don't quite know why, but they always equate their findings to vegetables or food or something like that. And if you think about it, this is a salmon pink color. You talk about a nutmeg liver. We talk about a carcinoma of the breast cutting like a ripe pear, all sorts of things. So we always relate it to food. I don't quite know why, but we do. And so that's a good example then of amyloid in the liver, at least in the kidney, secondary to a patient with myeloma. And then going to this particular patient, now you can see this abundant amyloid that is being deposited in the sinusoids. And you can see the compression of the hepatocytes. Now, one of the other tricks you can also do with Congo red and the staining is to see if it is birefringent. And the last time I looked, I couldn't demonstrate birefringence on this when I reported it initially. And it's birefringence under polarized light. Doesn't always work, but if it does work, you're supposed to see apple green birefringence. So let's see if it works. So the screen will go dark. And all I'm seeing on my screen is a black screen. And I don't think I can see it on the microscope. I can see a little bit of that. I think it's not really strong enough to transmit. Yeah, so it hasn't, not good enough for the purposes of the meeting. So a little bit of apple green birefringence, not particularly striking. Then the other thing that we can also do is we can pre-digest it. We can do the Congo red with and without potassium permanganate. So this particular Congo red here, as the stain has been done without pre-digesting the section with potassium permanganate. And what we can do is we can distinguish between AL amyloid, which is associated with plasma cell dyscrasias, and AA amyloid, which is associated with chronic infections and diseases such as rheumatoid disease. It also, remember that there's also transthyretin amyloid as well. And that, in fact, the subtypes of amyloid are growing all the time as we find different proteins that are deposited. For example, one of the things that you also get is amyloid deposition in patients who have dementia as well in the brain. So, but for the purposes of this discussion, AL amyloid and AA amyloid can be separated using pre-digestion with potassium permanganate. In AL amyloid, the staining characteristics are retained, and in AA amyloid, the amyloid is sensitive to potassium permanganate digestion. In this particular instance, it didn't work. The potassium permanganate, in fact, took away the staining of the Congo red. So that suggested it was AA amyloid, but in reality, it's actually AL amyloid. It's not absolute, and the best way, obviously, is to see if the patient has a plasma cell dyscrasia or not. So a nice example of amyloidosis, systemic amyloid,
Thanks,
which gets
Prof.
deposited in spaces. Nice case. Any questions? And it can, just for completeness, it can stain with a number of other stains as well. So this is the Masson trichrome, and you can see it picking up there too, nicely demonstrated. This typical amorphous appearance. I mean, you could take a picture of that and put it on your lounge wall. Would be a good talking point, wouldn't it, Chris? Look at that. I mean, you could put that, yeah. In fact, we could sell that picture and make it to the puzzle makers.
Then what were the enzymes?
So, Prof, she had normal bilirubins. She had an alk phos of 256, gamma GT of 699, an ALT of 36, and an AST of 38.
Yes, I mean, it's quite interesting that there was elevation of the gamma, and wonder why that should be there.
Gamma GT.
Mm,
But it's non-specific, Martin.
yeah,
It really is all over the place. I mean, the specific one to hang on to is the alk phos.
yeah.
And treatment, Dinan?
So, Prof, she had interrupted her latest cycle of bortezomib due to side effects. So our hematologists were still developing a new regimen for her. But their main question to me was, do I think there was progression of the amyloid deposition in her body? Because they were hoping it had settled. Her kidney function had improved slightly with the previous treatment. But it was just this new hepatomegaly that they'd picked up.
Yeah, and this is the PAS stain, and it also shows a very nice, almost sort of negative staining of the amyloid, because the PAS stain is picking up the glycogen in the hepatocytes, so it highlights those very strongly, whereas the amyloid is this pale staining material in between. Yeah, it's a one-look diagnosis. Good case to get in a part 1 exam, because you can sort it out very quickly and move on to the next case. Okay, any
And
questions?
it answers Wisdom's question, 2 questions as well.
What are those questions?
They were, how do you
Oh,
treat it?
yes,
What were
pathology.
what were the liver functions?
Yes,
Okay.
perfect.
Okay, so happy with that, Dylan. Happy, Wisdom? So the
Prof,
question is, do we have a differential diagnosis? Not really. No, it's a one-look diagnosis when you see it like this. Yeah, it's pretty typical. Okay. All right. Let's move on to the next one then.
Can I just ask a question quickly?
Sure.
yes.
We're running on battery power and Africa power down here, so we've got intermittent black holes. But can I just ask, having missed the point, is this amyloid a complication of the disease or a complication of the treatment?
So complication of the disease.
Thank you.
So the patient has a plasma cell dyscrasia. So, so Dylan, perhaps you could, I didn't pick it up, the electrophoresis, what did that show?
So, Prof, her urine Benz-Jones proteins were positive. She had lambda light chains on the renal biopsy, and her markers were in keeping on flow cytometry with the plasma cell dyscrasia. So they were all sort of tied in well together.
Yes.
And the fact that she had a treatment interruption together with this worsening, we blamed it on disease progression.
Yeah. And I think just referring to the, excuse me, the previous question about the differential diagnosis for the histopathological appearances, whilst I sort of glibly said it was, you know, it was amyloid, I think the differential diagnosis really rests in the identification of the cause of the deposition. So whether it is light chain disease or SAA or ALL or transthyretin globulin as well. That's really where the differential comes into. Okay. Okay. Shall we move on?
We move on to our second one.
Yeah.
The Prof, we've got Mr. VDS, a 59-year-old gentleman who received a lung transplantation in 2010 for alpha-1 antitrypsin deficiency. He was PIZZ with an alpha-1 antitrypsin level of 0.4. His pulmonologist had noted this progressively worsening infiltrative LFT. However, there were no features of cirrhosis or portal hypertension on imaging, and was referred to us for further evaluation. In terms of his liver function test, his bilirubins were 10 and 2. His ALT was 73, AST 140, alkaline phosphatase of 265, gamma GT of 366 with an albumin of 28. His INR was preserved and has never had any other features of synthetic dysfunction besides the low albumin. This was initially attributed to his multiple episodes of lung rejection and recent severe COVID infection. And as part of his workup, we did the MRI liver with Primavist, where the gross architecture of the liver looked normal, but they did note a possibly speckled parenchyma, but no features of portal hypertension with a normal spleen, no ascites, and no other features found. So we proceeded to do a liver biopsy, expecting to find alpha-1 antitrypsin liver-related problems.
Thanks, Dennis. So this was another fascinating case, and it is a wonderful example of alpha-1 antitrypsin deficiency. So the first thing I'm going to put on is the Sirius red stain. And this is the Sirius red. And you can see that there is extensive architectural distortion. We've got markedly expanded portal tracts by collagen deposition. There is evidence of linking. For example, you can see there that there's linking, I think, portal central linking and also portal linking. And there's also increased parenchymal fibrosis as well. So there, for example, that's a good example where you've got portal and portal central linking. And if we go down and have a look here, I think this is portal. One can pick up a bile duct. This is a bile duct there. So you've got increased portal fibrosis, then you've got this linking going across here, and then that's a central vein. And I was saying earlier in the first case, the degree of fibrosis and collagen deposition that you get around the central vein, and this is more than one would normally expect. So on the low power examination, then you can see that we've got portal and portal central linking. So this is a cirrhotic liver. And then you've also got some pericellular fibrosis as well in the parenchyma, such as you see there, almost chicken wire type fibrosis. And that picture is replicated through the whole biopsy. So we know then that he is cirrhotic. We also know that he's got alpha-1 antitrypsin deficiency. And if we look at the reticulin stain, this is the reticulin stain, which just portrays the pathology in a different color, but also shows you the trabecular disarray. For example, we haven't got the liver cell plates all lined up. They're all in a jumbled up manner. And then you can also see foci twinning of liver cell plates, such as you see there. You can see 2 cell thicknesses, not all the way through, but certainly for most of it, you can see that we've got hepatocyte twinning. There's a good example there where most of that nodule shows hepatocyte twinning. Excuse me, and you can see the extensive trabecular disarray. There's no orientation at all of those liver cell trabeculae, and more twinning there. So a very good example then of cirrhosis. And as you've heard me say in the past, the diagnosis of cirrhosis is one thing, but it's important to establish the cause of the cirrhosis so that the patient can receive appropriate therapy. This is the H&E, and if we look at the H&E, you can see that the portal tracts are expanded, as we've seen. There's also a lymphocytic inflammatory infiltrate. We've got a bit of a blue biopsy. You can see these portal tracts have, in addition to the fibrosis, we've got these blue areas, and this represents a lymphocytic inflammatory infiltrate. Could be plasma cells as well. Another area there too. And if we have a look at those, we can see that it is predominantly lymphocytic. We've got a bile duct which is caught up in that. So the diagnosis of this then would be a chronic hepatitis. Okay, so now we've diagnosed it as cirrhosis. We've now said that it is a chronic hepatitis, so that's the cause of the disease, at least the cause of the cirrhosis. Now we need to try and identify what the cause of the chronic hepatitis is. So obviously you've got to think of viral hepatitis, and so on. List can be as long as your arm. And one of the hepatitis is alpha-1 antitrypsin deficiency. I'm trying to select areas. And if we look there, you can see that you've got these small eosinophilic globules, such as that, in the cytoplasm. So these are intracytoplasmic globules. Now, in many cases of alpha-1 antitrypsin deficiency, this is what you see, because I'd hate you to go away with the impression that what you're about to see is what you see in all cases for 1 antitrypsin deficiency. This case is an absolutely overwhelming case of alpha-1 antitrypsin deficiency. So I would hate the pathology registrars to think that it's as easy as diagnosing alpha-1 antitrypsin deficiency as you see in this case. So this is often the sort of situation, this is the degree of detail that you need to look for. And you need to look for it in the paraseptal hepatocytes. In other words, adjacent to the fibrous connective tissue. Don't look for it in the middle, you won't see them. Seeing if I could pick up small numbers. And you need to be, so this is, I don't want to delay it too much, but that's the sort of thing there, okay? So now then, let's go and look at the rest of the biopsy. So this then is a case of florid alpha-1 antitrypsin deficiency. And here you've got the globules. So look at these. Massive globules. These are all intracytoplasmic globules of alpha-1 antitrypsin deficiency. And as I said, that's not what you normally see. Normally you see those tiny little globules that you've got to search for. And often, in fact, particularly in children, they're not readily evident. But in this case, there are hundreds of these globules. Look at all these. Really is a wonderful example of alpha-1 antitrypsin deficiency. So what happens is that because of the genetic defect, what happens, you get accumulation of the folded protein, and it cannot be exported by the liver. And consequently, it builds up in the liver tissue, in the hepatocytes. So this is an example, and they are PAS-positive diastase resistant. And if we go straight to the PAS-positive diastase stain, we'll see that they light up. Look at that. It's really quite striking. And please don't let me give you the impression that this is what all cases of alpha-1 antitrypsin deficiency look like. But that's it's an overwhelming example. I mean, you could put this in a textbook. This is a textbook case of alpha-1 antitrypsin deficiency. Look at these. And notice the distribution. So you're under low power. Can't quite, well, you can see them. So, for example, this is the fibrous connective tissue there. Here you've got the globules in the cytoplasm of the cell, and here there is nothing. Okay, so you need to make specific, pay your attention to the paraseptal hepatocytes. Don't look for them here because you won't find them. In this particular instance, because of the overwhelming nature of the disease, they're also present in the center of the lobules as well, such as that there. There's also a bit of steatosis as well. And then the other thing that you also see is sometimes you get accumulation of copper-associated protein on these globules. And this is no different. And here you've got a little bit of copper-associated protein in some of the hepatocytes. And you can see that, for example, here, once again in paraseptal hepatocytes there. So this is an example then of alpha-1 antitrypsin deficiency leading to cirrhosis and also lung disease. Excellent case. Thanks, Tanan.
Thank you for that, Prof. I don't see any questions in the chat.
I don't know, 2 points, Martin, the liver cancer risk in alpha-1 antitrypsin, particularly with the Z allele, it is increased independent of the risk that cirrhosis would contribute.
Sure.
So these patients have to be screened very carefully for liver cancer.
Yeah. Yeah, it's like the hemochromatotics.
Yeah, the same kind of risk.
Same sort of risk, yeah. Sure.
And then the second point is that heterozygotes are not free of liver disease. You know, they can actually aggravate underlying chronic liver disease of any cause. So it's worth searching, although I'm not sure what you'll do, Dylan.
Yeah, Prof, it's one of those where we check it because we're looking for a second etiological factor, but we don't actually end up doing too much about it at the end of the day.
And the pathogenesis?
In terms of the accumulation of the abnormal protein?
Is that the contribution to aggravating underlying chronic liver disease?
I think so, Prof.
Not immune related or...
No, you can in the heterozygotes, if I could just pop butt in there, in the heterozygotes, you can see small globules sometimes.
So it's a mechanical thing.
Yeah, and the other thing I didn't mention and should mention as well here is that I'll just go back to the past diastase. It's important that the liver specials that we do, they're done for a purpose, and they sort of stood the test of time. So you need to do a serious red because that's a very good stain. It's a sensitive stain for picking up increased collagen deposition, and you must do a PAS and a PAS diastase. And of anything, the PAS diastase is probably more important than the PAS. The reason for that is twofold. First of all, the PAS diastase picks up steroid pigment. So if there's a patient, for example, and steroid pigment is the tombstone of previous hepatocytes, and you find that in portal-based macrophages and also in the Kupffer cells. So that'll tell you if there's been a previous inflammatory episode in the liver. But the other thing that's also important is that you need to identify or make a specific point of looking in the paraseptal hepatocytes and for the alpha-1 antitrypsin globules. And I was lucky enough, I mean, that was demonstrated to me very clearly just about probably a year or 2 years ago. And I was asked to review a biopsy of a patient. There was a teenager, and she had and Chris, you'll have to help me here, but if my memory serves me correctly, in alpha-1 antitrypsin deficiency, you get specific elevation of the ALT. Is that correct?
Not aware of that.
So it's in fact it might be the ALP, because this patient.
Yeah, more likely that than ALT. Because of the globule. The globule effect.
Yeah, no, it's one of the transaminases. It's one of the transaminases that goes up. Perhaps somebody could just do a quick search while I'm talking.
I'm doing it, John.
But it's either AST or ALT, and it just seems to pick up that. And this was a young woman who was a teenager, and she had an abnormal liver enzyme. And I was asked to look at the biopsy, and did. And sure enough, on this particular thing, on the PAS diastase, there were small globules like this in the hepatocytes. And I suggested to the physician concerned that they look for alpha-1 antitrypsin deficiency. And in fact, it turned out that she was heterozygote for alpha-1 antitrypsin deficiency. And that meant then there was a whole investigation that was then done for the family as well, because there were siblings as well. And in fact, she indeed was a heterozygote for alpha-1 antitrypsin deficiency. So it's important because you'll only see this on the past diastase. So it's an important stain to look at. Have you found it, so Chris?
No, well, it's, I mean, the article that I see does not, I mean, LT does not. So it might be an AST elevation.
Yeah, I know one of them is, it's a specific marker. It could, I mean, it could even be the ALP. I may be wrong.
There's a question from Wisdom.
Wisdom.
There's a question from Wisdom.
Here's
an
to you,
important.
Prof.
Yes, my question, Prof, I'm sure you could read it. I was wondering how many, when it gets all the way to cirrhosis, will alpha-1 antitrypsin findings you have described, are they pathognomic for alpha-1 antitrypsin, or they could other chronic hepatitis, like viral hepatitis B, giving you a similar picture? Because I'm wondering how many cirrhotics could be missed when it was alpha-1 antitrypsin, and by the time you do a biopsy, you do not know whether it was the alpha-1 antitrypsin or it is. So my question is, what you described, 100% says this is alpha-1 antitrypsin in any pathology lab. Am I correct or not?
Yeah, so you're correct. So it's unlikely that you will get those sort of those inclusions in viral hepatitis. When you get these eosinophilic inclusions, and I must tell you that I've battled with a couple of cases as well, not in relation to viral hepatitis, but in relation to copper-associated protein, because sometimes I've seen patients who've got demonstrable copper-associated protein. So, for example, let's go to this here. So if we go, I'll find it again. So in some patients, I've seen copper-associated protein like that there. And the teaching is that when you see copper like this, that you've got to think of chronic cholestatic liver injury, things such as PBC, PSC, and so on. And then sometimes that copper-associated protein can also be positive diastase resistant. And then it becomes quite a problem to sort out. And one then has to revert to, I mean, quite honestly, doing the alpha-1 antitrypsin deficiency levels, sorry, not deficiency, the alpha-1 antitrypsin levels to ascertain whether the patient indeed does have alpha-1 antitrypsin deficiency. Because if you go into the literature, alpha-1 antitrypsin deficiency is actually quite common in the population. And Chris, once again, maybe you can look those figures up, but the heterozygosity in the population is frequent, and it is not unheard of. I know that Prof. Song, we had a patient whom we transplanted a few years ago for alpha-1 antitrypsin deficiency, and post-operatively, the alpha-1 antitrypsin deficiency, the alpha-1 antitrypsin levels didn't.
Yeah, Martin.
In fact, was given a liver that was heterozygote for alpha-1 antitrypsin deficiency.
So a couple of findings here.
Yeah.
Sorry, Martin. Yeah, in fact, the incidence of the heterozygosity can be up to 15% in the normal population.
15%, you say, Chris?
Yeah, 10 to 15%.
Yeah. Yeah, no, it can be very high. So that's why it's important to look for those past positive diastase resistant globules, because they can have. Sorry, Chris, carry on.
No, you carry on. Sorry.
So that's why it's important to look for those globules. So Wisdom, I'm not sure if I've answered your question. You wouldn't get those globules in chronic hepatitis.
I think also.
No, you have on
does
PS. You have answered.
Does the distribution of the globules change as the liver progresses to cirrhosis?
No, it stays in the paraseptal zone 1.
And are they as prominent?
Well, what will happen is that as the patients get older, then the amount of the protein in the hepatocyte increases. So it stands to reason that as patients age, and this is probably quite a good example because he's 59. So most of the patients that we are diagnosing with alpha-1 antitrypsin deficiency-induced liver disease are younger than that. And when you've got
from a clinical point of view, then it's not going to be an important cause of burnt out cirrhosis. You should be able to pick it up on pathology.
You should be able to, yeah, except in the neonates or the young infants, because you may not have enough accumulated protein. Wisdom, does that answer? Have we answered your question?
Yes, Prof, you have answered. Yes.
Great. Good.
Another question, Martin. How common is this disease in Black Africans?
Yeah, I saw that question, and I'm not sure. I don't know. I don't know the answer. Dylan, yeah, you answer.
So conventionally, it's been regarded as a disease of Caucasian Europeans.
Yeah.
But over the generations, due to a bit of mixture through the ancestry, we have seen it a lot more in our mixed ancestry population or colored population, and we are actually seeing it in some of our African population. So there are actually databases of this available online, which actually split it up between our Zulu, Xhosa, Tswana, Ndebele, Pedi, Venda groups as to how commonly they've seen these based on these registries. What's interesting is that it varies quite far in the different groups around the sub-Saharan African region in terms of the local population. So it's not a set rate for a certain race, but it's filtered through over time, and there are actually stats out there on the frequency in South Africans.
Yeah, that was my sort of thoughts as well, Dylan. Yeah.
And then finally, Martin, it might be gamma GT that has a propensity for alpha-1 antitrypsin.
Oh, okay. Yeah.
I've just done a quick search.
Yeah. Yeah. Thanks. But because I know this particular teenager, that was the only enzyme that was elevated, and then when I looked it up, it said that that's one of the clues when you look at the liver enzymes. Okay, time is moving on. We've got one more case.
Sure, Prof. So we have Mr. IN, a 61-year-old gentleman who initially presented to our unit in 2021, where he was evaluated and biopsied and thought to have a allopurinol-induced vanishing bile duct syndrome. He did not have features of advanced fibrosis or cirrhosis at the time. And he was left on a bit of, I think one of my colleagues had started him on Ursofoc, and he's been monitored in terms of his liver function tests thereafter. His most recent follow-up, his imaging suggested a slightly nodular liver. However, his LFTs had actually improved over time. His billies were 23 and 11. His ALT was 29, AST of 40, ALP-FOS of 120, and gamma of 79. An extended serological workup was initially done, which revealed elevated immunoglobulin A, G, and M. He had a serum calcium that was elevated, a serum ACE elevated. He was Hep B core positive with previous and now immune. He had a borderline positive soluble liver antigen and a borderline positive ANA, which was speckled in terms of his workup. And due to these variety of positivities found, Bilal chose to biopsy his liver. And I think that's what you have.
This is an amazing case again. And this particular patient was interesting because when he presented the first time round, we did quite a lot of sort of investigative work on him. And what happened was we found that he had a vanishing bile duct syndrome, as Bilal, at least as Dylan mentioned. And anyway, so we went into his drug history, and there was nothing in particular in that drug history. And then I said to Bilal, well, let's just go back a bit further into his blood history, into his drug history. And he came up with the fact that he had taken allopurinol, the patient had taken allopurinol. And a patient then mentioned, just casually, that that's when his problem started. So he related certainly onset of his symptoms to the taking of allopurinol. And if you go into the Liver Tox website, and those of you, I'm sure you all know the Liver Tox website, registrars that are on the meeting may not, but always go ask what drugs the patient is on, and persist. We've all had patients, and Prof. Cassanides will remember one particular patient where the patient had forgotten that he was taking a particular medication. You remember that patient?
Margarone, yeah.
Yeah. And we suggested, for example, I said to Prof. Cassanides, this patient's this is alcohol. It wasn't alcohol, and everybody forgotten that the patient was taking amiodarone, and in fact that was the cause of his drug-induced liver injury. So you've got to really dig and dig and dig. And anyway, this particular patient was taking allopurinol, and if you go to the Liver Tox website, it is a recognized cause of drug-induced vanishing bile duct syndrome. So we were quite happy with that, and moved on to the next patient. So as Dylan has mentioned, he was rebiopsied because the patient was not. He seemed to have progressing fibrosis, but his liver function, although it improved, and it had improved over the course of time. So this is the repeat biopsy. So his first biopsy was done in 2021, and this is the repeat biopsy. And here, right bang slap in the middle of the portal tract is a granuloma. And this is a typical sarcoidal granuloma with multinucleate giant cells. You couldn't get a better example of sarcoidosis of the liver. And this has produced extensive portal fibrosis, which is probably progressing now to cirrhosis. You can see that through the whole core of the biopsy. And in some areas, there is coalescence of these granulomata, as you see there. They're non-caseating, they are clean, and typical sarcoidal granulomata. Now, the interesting thing is that sarcoid is also a cause of vanishing bile duct syndrome. And we went back, reviewed the biopsy from 2021, and there is no evidence of any granulomatous inflammation. So he didn't miss sarcoid at that particular time, not on the biopsy. I dare say it could well have been representation, did we pick up granulomata? Did the biopsy miss the granulomata? Well, we don't know. but certainly there was no granulometer in the biopsy at that time. So I thought I'd just show you this one as from 2 points of view. First of all, the sting in the tail that we attributed this to allopurinol. It could well be allopurinol induced, but the sting in the tail here is that in fact he had sarcoid. So yeah, the patients had the last laugh, and yeah, it's a very good example of sarcoid. And sometimes you get the sarcoidal granulomata in the parenchyma, not just the portal tracts. So there's another one. There are no asteroid bodies in this. Notice that and that's a good example of a clean granuloma. And when we say, why do we call them clean granulomata? Because there's minimal associated inflammation. It's just a cluster of epithelioid histiocytes. And sometimes, as I said, you see them in the parenchyma, and they weren't particularly well represented in the parenchyma in this particular instance. But if you get granulomata, and this is a tip for the histopathologist, if you get granulomata in the parenchyma, then you always want to do a mass on trichrome, because the mass on trichrome in patients who have intraparenchymal sarcoidal granulomata, the mass on trichrome will demonstrate perigranulomatous fibrosis. And that's a good way to separate out the granuloma in the liver secondary, say, to tuberculosis, which, because TB can do this as well, to separate it out from sarcoid. In TB granulomata in the liver, typically those granulomata are not surrounded by fibrosis. So that's a little sort of practice tip, if you like, that one can use. But yeah, I think it's a very good example. So that brings us to the end of the 3 cases. Just on 4:30, a minute or 2 to go.
Thank you, Prof. So in our last minute, I'd just like to thank Prof. Hale and Prof. Cassanides for leading us through these amazing cases. I'd like to also thank ECHO University of New Mexico and the ECHO India team for the support. The recordings will be available on the Gastro Foundation website. And with that, I'd like to thank the Gastro Foundation too for allowing us to have these lovely talks on a weekly basis. Thank you to all the sponsors. And I think next week we have endoscopy coming up. And
So,
with that, we can...
Dylan, sorry, there's just one question here from Wisdom again.
Oh.
Wisdom, would you like to just answer?
I've just checked on the allopurinol versus sarcoidosis. That allopurinol causes granulomatous hepatitis as well on up to date. I was wondering whether it was coincidence.
Yeah. I mean, you're absolutely right, Wisdom. I mean, I hadn't read that on liver tox, but his so his serum calcium's elevated, and his ACE is elevated as well. So, yeah, as I said, the patients have the last laugh, don't they? I mean, does allopurinol cause elevation of serum calcium and ACE? Do you know, Dylan, Chris?
Unlikely.
Unlikely.
You stopped allopurinol, Dylan.
We stopped 2.5 years ago.
Yeah,
so unlikely to cause it now.
Yeah. But I mean, Wisdom, you raise a very important point. You know, that when we see granulometry in the liver, as everybody does, our hearts sink, because the causes of granulometry in the liver are, I mean, it's as long as a piece of string. But that's a good point. Thanks. I wasn't aware of that.
Thank you, Prof.
Sorry, Dylan, I interrupted you there. I thought it was
no.
Wisdom.
Thank you. I didn't see that. But I'd just like to thank everybody again, and thank you, Prof. Hale, and have a lovely evening, and see everyone next week for endoscopy.
Thanks, Dylan. And Martin, welcome back. Thanks very much.
Yeah, thanks, pleasure. Thanks for the invitation. Keep well. Bye then.
Okay, bye-bye.
Bye.